When encountering a patient presenting with fever, cough, and shortness of breath, pneumonia should be high on your differential diagnosis. An effective approach to the diagnosis and management of pneumonia involves several key steps, tailored to integrate clinical judgment with evidence based practices. This approach not only aids in the accurate identification of pneumonia, but also in determining its etiology, severity, and the most appropriate treatment strategy. Community-acquired pneumonia, also known as CAP, stands as a significant cause of infections leading to hospital admissions across the U.S., exhibiting a range of severity from mild to life-threatening cases. Its prevalence increases with age, particularly affecting adults over 80 years old at a much higher rate compared to those under 50. Recent studies have led to the reclassification of healthcare associated pneumonia, also called HCAP, under CAP, due to minimal differences in the microorganisms and comorbidities in affected patients, unlike hospital acquired pneumonia, also called as HAP, which remains separate due to distinct characteristics. Community acquired pneumonia typically results from viral or bacterial infections, with a varying likelihood of specific pathogens based on patient age, existing health conditions, and environmental factors. Streptococcus pneumoniae used to be the leading cause of bacterial pneumonia, but is a less common cause nowadays, thanks to vaccination efforts. Whereas incidences of infections by other bacteria, like Staph aureus, Pseudomonas, and Enterobacteriaceae, are on the rise. Both fungal and mycobacterial infections are not commonly associated with CAP. Identifying keywords related to the cause of pneumonia is important. For example, a patient with a history of alcoholism presenting with pneumonia may indicate an infection with either strep or Klebsiella. Individuals over the age of 65 diagnosed with pneumonia are at increased risk of exposure to influenza, strep, or rhinovirus. Pneumonia following a viral illness, such as influenza, is commonly caused by staph, strep, pyogenes, or streptococcus pneumoniae. Exposure to a hot tub or air conditioning units followed by a diagnosis of pneumonia suggests a possible infection with Legionella. A patient with pneumonia who has been exposed to birds may indicate chlamydia psittaci infection leading to psittacosis or parrot fever. This infection results from inhaling bird droppings, which could either be urine or fecal material. Similarly, a farmer involved in birthing process of farm animals such as sheep, goats, and cattle and presenting with pneumonia might be infected with Coxiella burnetii, the bacterium responsible for Q fever. A patient residing in a crowded rat-infested dwelling and diagnosed with pneumonia may have been exposed to the hantavirus transmitted through inhalation of aerosolized rodent excrement or urine. Atypical pneumonia includes infections by pathogens not detected on standard bacterial cultures, such as Legionella and Mycoplasma. While anaerobic bacteria were once considered significant, recent studies suggest their role in community-acquired pneumonia is limited to specific conditions like lung abscesses or empyema. A pneumonia diagnosis includes two or more clinical findings of pneumonia and chest imaging. Two or more clinical findings include new or increased cough, sputum production, shortness of breath, fever, or rales. And chest imaging can be a chest x-ray or a chest CT. A 65-year-old man presents to the ER with a 3-day history of fever, productive cough with yellowish sputum, and shortness of breath. He has past medical history of COPD and hypertension. He is a current smoker with a 40-pack year history. On physical examination, his temperature is 100.9 Fahrenheit, heart rate 102 beats per minute, respiratory rate 24 breaths per minute, oxygen saturation of 92% on room air. Auscultation of the lungs reveals crackles in the right lower lobe. Lab tests show a white cell count of 15,000 in the left shift. A chest x-ray is ordered. Which of the following findings on a chest x-ray is most indicative of pneumonia in this patient? Hyperinflation of the lungs, bilateral hilar lymphadenopathy, consolidation in the right lower lobe, curly B lines, or pneumothorax. The correct answer is consolidation in the right lower lobe. This patient's presentation is consistent with community-acquired pneumonia, particularly giving his symptoms of fever, productive cough, and shortness of breath, along with physical examination findings of crack holes in the right lower lobe and laboratory evidence of leukocytosis with a left shift. The chest x-ray finding most indicative of pneumonia is consolidation, which refers to the filling of alveoli with fluid, pus, blood, cells, or other substances, resulting in an area of increased opacity on X-ray. In this case, consolidation in the right lower lobe correlates with the clinical findings and supports the diagnosis of pneumonia. Hyperinflation of the lungs is more characteristic of COPD or asthma exacerbation. Bilateral hilar lymphadenopathy is more suggestive of conditions like sarcoidosis or lymphoma. Curly B lines are associated with interstitial edema and are commonly seen in heart failure. Pneumothorax is characterized by the presence of air or gas in the pleural space and would not be present with fever and leukocytosis. Chest X-ray findings can provide a hint at the causative organisms of pneumonia. Lobar pneumonia often suggests strep pneumoniae or Legionella. Lung abscesses or cavitary lesions point towards oral anaerobes, Staph aureus, Klebsiella, Mycobacteria, or some endemic fungi. Interstitial infiltrates are indicative of atypical organisms, such as Legionella, Mycoplasma, and other viruses. The presence of a pleural effusion or empyema typically implicates oral anaerobes, Staph, or strep pneumoniae. A 23-year-old college student presents to the Student Health Center with a 2-day history of sharp pleuritic chest pain, dry cough, and malaise. He reports no significant past medical history and takes no medications. He lives in a dorm and mentions that several of his dorm mates have been sick with similar symptoms. On physical examination, his temperature is 100, heart rate 88 beats per minute, respiratory rate 20, and an oxygen saturation of 96% on room air. Auscultation of the chest reveals fine crackles in the right lower lobe. A chest X-ray shows interstitial infiltrates. Which of the following organisms is the most likely responsible for this patient's pneumonia? Strep pneumoniae, Mycoplasma, Klebsiella, Legionella, or Pneumocystis? The right answer is Mycoplasma pneumoniae. This patient's presentation is suggestive of atypical pneumonia, which is characterized by a more gradual onset of symptoms, non-productive cough, and extrapulmonary manifestations such as malaise and pleuritic chest pain. Mycoplasma pneumoniae is a common cause of atypical pneumonia, especially in young adults and in crowded living situations such as dorms. The chest X-ray findings of interstitial infiltrates further support the diagnosis of atypical pneumonia, which is often caused by Mycoplasma pneumoniae. This organism does not typically cause the lobar consolidation seen in bacterial pneumonias, but rather causes a more diffuse interstitial pattern of lung involvement. A 45-year-old female presents to her primary care doctor's office in early December with a 4-day history of sudden onset of high fever, dry cough, severe muscle aches, and fatigue. She reports that several coworkers have been out sick with similar symptoms. Physical examination findings include a temperature of 101.8, heart rate 88, respiratory rate 20, and an oxygen saturation of 95% on room air. She also has bilateral wheezing, but no crackles are noted. The rest of the examinations are remarkable. Given the patient's symptoms and the time of the year, you suspect influenza as a cause of her presentation. Which of the following is the most appropriate diagnostic test to confirm the diagnosis of influenza A in this patient? Order CBC, chest X-ray, sputum culture, rapid influenza nucleic acid amplification test, or a rapid influenza antigen test. The correct answer is D, rapid influenza nucleic acid amplification test. The rapid influenza nucleic acid amplification test is highly sensitive and specific for detecting influenza virus RNA over the previous rapid antigen test. It can provide results quickly, often with 15 to 60 minutes, making it an excellent choice for the timely diagnosis of influenza in a clinical setting, especially during flu season or in the context of an outbreak. This allows for the prompt initiation of appropriate antiviral therapy, which is most effective when started within 48 hours of symptoms. Other options like CBC, chest X-ray, and sputum culture may help in the assessment of complications or differential diagnoses, but are not direct tests for influenza. Sputum gram staining cultures are recommended for patients admitted to the ICU, ideally using an endotracheal aspirate for those who are intubated, individuals who have not improved with outpatient antibiotics, those presenting with cavitary lung lesions, and those with pre-existing structural lung disease. It is not routine to obtain blood cultures in all patients presenting with pneumonia. Blood cultures should be reserved for those with severe pneumonia or for patients who are empirically treated for infections such as MRSA or Pseudomonas. Many patients with community-acquired pneumonia can be effectively managed on an outpatient basis. Clinical prediction models help identify individuals who can be safely treated outside the hospital setting. The Pneumonia Severity Index is a reliable tool for predicting all-cause mortality within 30 days. It assesses 11 variables linked to adverse outcomes. Patients classified as severity risk class 1, with no risk factors are typically suitable for outpatient management. While the PSI is useful for making decisions about where care should be provided, it should not override clinical judgment. Compared to the CURB 65, the PSI is preferred because it identifies a larger group of low risk patients and more accurately predicts mortality risk. The Pneumonia Severity Index stratified patients with pneumonia into 5 classes for risk of death from all causes within 30 days. It requires 2 steps. Step 1 is to identify the patients in the lower risk class, which is risk class 1, without relying on lab tests. In risk class 1 patients, patients are less than 50 years old and without any coexisting conditions and absence of physical examination findings. If one or more risk factors are present, then proceed to step 2, which considers lab and radiographic information. A total point score is computed by adding the patient age in years, years minus 10 for females, and the points for each applicable risk factor. Total scores of 70 or under corresponds to class 2, which is outpatient recommendation. 71 to 90 to class 3, which could either be outpatient or inpatient, 91 to 130 for class 4, which dictates inpatient management, and over 130 to class 5, which considers inpatient management. Compared to CURB 65, the PSI is preferred because it identifies a larger group of low risk patients and more accurately predicts mortality risk. However, CURB 65 is also a good tool to memorize for your exams to determine if the pneumonia management should be done in an inpatient or outpatient. CURB 65 stands for C for confusion, U for urea, R for a respiratory rate of more than 30, blood pressure is for less than 90, and age of more than 65. For otherwise healthy patients who do not require hospital admission, the recommended treatment regimens are monotherapy with either doxycycline or amoxicillin. The use of macrolides such as azithromycin and clarithromycin is now recommended only in regions where the prevalence of pneumococcal resistance in this class of antibiotics is known to be below 25%. Also, it is important to note that macrolides and quinolones can extend the QTC interval. Therefore, alternative medications should be considered for patients at risk for torsade. This includes individuals with a history of long QT interval, those with other medications known to lengthen the QT interval, and those with electrolyte imbalances. Patients who have not shown improvement with prior CAP treatment regimen but still qualify for outpatient care should be treated with a medication from a different class. A 35-year-old female presents with cough and fever for 2 days. She is healthy and not on any medications. Her temperature is 100.9 Fahrenheit, blood pressure 120 over 70, heart rate 80, respiratory rate 18. She has an oxygen saturation of 93% while breathing room air. Examination reveals decreased breath sounds at the base of her right lung. Her COVID 19 test result is negative. A chest radiograph reveals an infiltrate in the right lower lobe. Considering her clinical presentation and findings, what is the most appropriate choice for treatment? Amoxicillin, a combination of ceftriaxone and azithromycin, a combination of ceftriaxone and doxycycline, or levofloxacin monotherapy. Amoxicillin is the most appropriate therapy in this patient. Her score in the Pneumonia Severity Index screening scale is 0. Therefore, outpatient therapy for community-acquired pneumonia is appropriate. In healthy persons, treatment options are amoxicillin or doxycycline. A 55-year-old man with history of COPD and type 2 diabetes presents to his primary care physician with a 3-day history of increased cough, yellowish sputum production, and fever. On physical exam, his temperature is 101.3, blood pressure 130 over 85, pulse rate 98, and respiratory rate 22. Oxygen saturation is 94% on room air. Auscultation of the lungs reveals crackles in the right lower lobe. Given the patient's comorbidities and current presentation, which of the following is the most appropriate treatment? Monotherapy with amoxicillin, azithromycin, ceftriaxone, or a combination of amoxicillin clavulanate and azithromycin. Since the patient is over 50 years old, then his PSI is at least a class 2. Since he has no coexisting illnesses such as chronic liver disease, heart failure, cerebrovascular disease, or chronic renal disease, and his physical examination findings are not significant, his total score still puts him in a class 2. Since he is at low risk with a PSI of class 2, No arterial oxygen desaturation or psychosocial contraindications to outpatient therapy, a combination antibiotic regimen is preferred. If the patient has severe penicillin allergy, then the appropriate management is monotherapy of levofloxacin. A 45-year-old man presents to the emergency room in December with a 2-day history of worsening shortness of breath, fever, and a productive cough with yellowish sputum. He also reports body aches and severe headache. He has not received the influenza vaccine this season. On physical exam, his temperature is 102.2, heart rate 110, respiratory rate 28, and an oxygen saturation of 89% on room air. Auscultation reveals bilateral crackles and wheezing. A chest x ray shows bilateral infiltrates, and a rapid influenza nucleic acid amplification test is positive for influenza A virus. Given the patient's symptoms and imaging findings, which of the following is the most appropriate treatment? Oseltamivir only, a broad spectrum antibiotic only, oseltamivir plus a broad spectrum antibiotic, inhaled steroids, or supportive care. The correct answer is oseltamivir plus a broad spectrum antibiotic. This patient presents with symptoms of influenza, confirmed by a rapid influenza nucleic acid amplification test, complicated by bacterial pneumonia, as evidenced by his productive cough with yellowish sputum, high fever, worsening shortness of breath, and bilateral infiltrates on chest x-ray. Also, tamivir, an antiviral medication, is indicated for the treatment of influenza and is most effective when started within 48 hours of symptom onset. However, given the clinical and radiographic evidence of bacterial pneumonia, the addition of broad spectrum antibiotic is warranted to cover potential bacterial pathogens, including strep pneumoniae and Haemophilus influenzae. When considering empiric therapy for pneumonia, we have to identify patients who are at risk for certain organisms such as MRSA and Pseudomonas. Risk factors that indicate need for empiric therapy against MRSA includes known colonization or prior infection with MRSA, gram-positive cocci clusters in the sputum, receive IV antibiotics during hospitalization in the last 3 months, recent influenza-like illness, patients with necrotizing or cavitary pneumonia, or patients with the presence of empyema. Risk factors for MRSA colonization includes end-stage renal disease, patients who are men who have sex with men, living in crowded conditions, incarceration, injection drug use, and contact sports participation. Risk factors that indicate the need for empiric therapy against Pseudomonas includes gram-negative bacilli seen on good quality sputum production, patients with known colonization or prior infection with Pseudomonas, patients who receive IV antibiotics during hospitalization in the last 3 months, patients with structural lung abnormalities, or patients with frequent COPD exacerbations requiring frequent steroids or antibiotic use. If a patient with pneumonia is hospitalized and requires antibiotics and has no MRSA or Pseudomonas risk factors, consider an anti-pneumococcal beta-lactam like ceftriaxone plus a macrolide like azithromycin. If the patient has pneumonia in the hospital with MRSA risk factor only, consider an anti-MRSA agents like vancomycin plus an anti-pneumococcal beta-lactam like ceftriaxone plus a macrolide. An alternative is a monotherapy with a respiratory fluoroquinolone like levofloxacin. If the patient is hospitalized with pneumonia and needs IV antibiotics and only has Pseudomonas risk factors, consider an anti-Pseudomonal fluoroquinolone like levofloxacin plus an anti-Pseudomonal anti-pneumococcal beta-lactam such as cefepime. If the patient is hospitalized with MRSA and Pseudomonas risk factors, consider anti-MRSA like vancomycin plus an anti-Pseudomonal fluoroquinolone like levofloxacin plus an anti-Pseudomonal anti-pneumococcal beta-lactam like cefepime. A 50-year-old man who was recently incarcerated presents with a 5-day history of productive cough, fever, shortness of breath, and pleuritic chest pain. He reports that he completed Tamiflu for an influenza infection a week ago. On examination, his temperature is 102, heart rate 110, respiratory rate 24, and an oxygen saturation of 90% on room air. Physical examination findings reveals a right-sided chest crackles. A chest X-ray shows a right lower lobe consolidation. Which of the following is the most appropriate antibiotic therapy for this patient? A. Vancomycin, ceftriaxone, and azithromycin. B. Vancomycin, levofloxacin, cefepime. C. Amoxicillin. D. Ceftriaxone plus azithromycin. The patient is at increased risk for MRSA. He was recently incarcerated and recently had an influenza-like illness. He has no risk factors for Pseudomonas. The correct answer is A. Vancomycin, ceftriaxone plus azithromycin. If the patient has MRSA risk factor, select a combination of anti-MRSA agent plus anti-pneumococcal beta-lactam regimen plus macrolide or doxycycline. Another option is anti-MRSA plus a respiratory fluoroquinolone. Option B is appropriate if the patient has MRSA and Pseudomonas risk factors. Option C is an oral therapy and is not appropriate since has significant clinical findings and should be hospitalized. Option D is the best option if the patient has no MRSA or Pseudomonas risk factors. A 65-year-old female with a history of hypertension and heart failure is admitted to the hospital with a 4-day history of productive cough, fever, and shortness of breath. She lives alone and is independent with her activities of daily living. On admission, her temperature is 101.7, blood pressure 150/90, pulse rate 110, and respiratory rate of 20. Oxygen saturation is 88% on room air, which improves to 94% with 2 liters of oxygen via nasal cannula. Physical examination findings reveals a dullness of percussion and decreased breath sounds at the right lung base. Lab tests show a white blood cell count of 15,000, and a chest X-ray confirms a right lower lobe consolidation. Which of the following is the most appropriate initial antimicrobial therapy? Azithromycin monotherapy, ceftriaxone plus azithromycin, ceftriaxone monotherapy, or vancomycin and piperacillin tazobactam? The correct answer is ceftriaxone plus azithromycin. The patient presents with clinical and radiographic evidence of CAP requiring hospitalization. The combination of ceftriaxone, a third-generation cephalosporin, and azithromycin, a macrolide, is a standard empiric therapy for hospital patients with CAP with no risk factors for MRSA and Pseudomonas. A 42-year-old female is hospitalized with acute respiratory failure after experiencing fever, cough, and shortness of breath for 2 days. She is not on any medications. She is intubated and on mechanical ventilation. A gram stain of an endotracheal tube aspirate reveals moderate leukocytes, moderate gram-negative rods, and some yeast. Her chest X-ray displays bilateral opacities. Given this information, what is the most appropriate initial choice for antimicrobial treatment? Cefepime plus levofloxacin, cefepime plus vancomycin plus levofloxacin, cefepime plus vancomycin plus azithromycin plus micafungin, or ceftaroline plus azithromycin. The most appropriate initial treatment for this patient is cefepime plus levofloxacin. Since she has no risk factors for MRSA, but the gram stain is showing gram-negative rods, she has Pseudomonas risk factors. In this situation, the patient will require an anti-pseudomonal, anti-pneumococcal beta-lactam such as cefepime, plus anti-pseudomonal fluoroquinolones such as levofloxacin. If the patient also presents with MRSA risk factors, then add an anti-MRSA agent like vancomycin. In conclusion, mastering the approach to the diagnosis and management of pneumonia is crucial in preparing for the USMLE Step 2CK and NBME Internal Medicine exams. This includes a comprehensive grasp of clinical assessment, judicious employment of diagnostic tests, accurate severity stratification, and implementation of evidence-based treatment protocols. Best of luck on your exams, and may your preparation lead to confidence and success.